Assalamu alaikum wa rahmatullahi wa barakatuh. Our lecture today titled Liver Cirrhosis and Portal Hypertension. Of course, liver cirrhosis is one of the most important subjects for doctors, and they must be aware of it, whatever their specialty in the future, because it is patients with liver cirrhosis are commonly met in the medical. Before we start with liver cirrhosis, we must know some information about the organ itself, the liver. Of course, all of us knows where is the liver. The liver lies in the right hypochondrium, just below the diaphragm, on the right side, in the upper part of the abdomen. As you can see here, this is the liver from an operative photo. It weighs about 1.5 kilograms. Of course, this weight is variable because if we get somebody who is tall and obese and his liver would not be, of course, 1.5 kilogram. It would be much more than that. It would weigh more than this. It's wedge shape, as we can all see. Most persons think that the liver is only two loops, right and left lobe. This is not correct. The liver is made of four loops, the right and left classic loop, and there are two smaller lobes, what's called the caudate loop and the quadrate lobe. So there are four lobes in the liver. The liver is one of the organs that has very rich blood supply. In fact, we say that it has a double blood supply. And unlike other organs, the main blood supply does not come from the artery that carries its name. It's not from the hepatic arteries. No, no. The hepatic artery would supply the liver with only 20%, 15%, 25%, and it's also variable between persons of the total blood supply of the liver. So what gives the liver its most blood supply, 80% remaining blood supply, in fact, from the portal veins. So the main arterial blood supply, or the main blood supply of the liver, comes from the portal vein, which is 80% almost from the blood supply of the liver, and only 15 to 25%, which is averagely 20% from the hepatic arteries, which carries the name of the liver. As we all remember from the histology, that the unit of the liver is called the acini, and between those acini there is the portal triad that carries a branch from the portal, and a branch from the biliary tract, and the branch from the hepatic. So these makes the liver comprised of lobules with surrounding a central vein. As we can see, the usual hexagonal shape of the hepatic lobules, and we can see that they are in a palisade manner above each other and beside each other. This is the look of the liver in a gross picture, and this is a 3D demonstration of how the hepatocytes are arranged in plates, and the hexagonals of the hepatic acini, and the portal triads that is carrying a branch from every thing, and the central vein that is in the middle of the hepatic acini. So this is the histologic look of the liver, and this is important for us to know later on about liver cirrhosis, why the liver starts to make regeneration nodules, because every unit of that starts to have its own fibrosis, and the fibrous tissue surrounds area that's trying to regenerate, and so it makes the regeneration nodules. But we will see this in a little while. Now we have known about the anatomy and histology of the liver. What about the function of the liver? Of course, the liver is called the kitchen of the body. Why it's called the kitchen of the body? Because it can synthesize things. It takes raw materials and they make them another things, like we do exactly in the kitchen. We can store things in the liver, exactly like we do in the kitchen. And also we bring things which are harmful, and then we detoxify it and we eliminate it exactly like we do in the kitchen when we detoxify something or cook something or trash something and so on. So this is why we call the liver the kitchen of the body. So let us revise together what are the functions of the liver, because when we know the functions of the liver, then after a while, when we speak about the liver impairment and how the liver is not functioning well, we will only think about the liver functions, and then we start to reverse them and impair them, and the liver manifestations of affection of the liver functions would be very easy for us. So the first liver function is metabolism. Of course, all of us know that the main metabolism of the carbohydrates, fats, and proteins happens inside the liver. And that's why this also explains that people with liver cirrhosis and the liver derangement, they have problems in the metabolism of such things, and they soon develop diabetes because they are unable to metabolize carbohydrates in the proper manner. Of course, secretory form of function, while like secrete bile and bile acids and salts and pigments, that is very crucial and beneficial and important in the digestion and absorption of fats and fat-soluble vitamins. Excretory function, which is the excretion of bilirubin, excretion of drugs and toxins. Of course, the most important is the synthetic function. The liver is the site where albumin is synthesized. Albumin, of course, is the main oncotic factor that is responsible for the plasma oncotic pressure, as well as the coagulation factors. So that's why when we have a liver derangement, we have abnormality in the coagulation factors and we have bleeding tendency. Storage, as we said, it is storage for carbohydrates in the form of glycogen, and we all know this cycle of fasting and feeding. And when we are fasting, we start to use the carbohydrates stored in the liver as in the form of glycogen by the process called glycogenolysis. And after a while, when this glycogen is all used, we start to generate new carbohydrates in using the metabolism function of the liver by gluconeogenesis and so on. And of course, you know all that from the biochemistry. It is the site of storage also of some vitamins, and the detoxification function, which is very important. It can detoxify toxins and ammonia. And this detoxification of ammonia explains to us why ammonia accumulates in patients with liver cirrhosis when the liver is unable to detoxify the ammonia, and it can go to the brain and make what's called ammonia encephalopathy or hepatic encephalopathy. Okay, one of the most important things we all remember is the bilirubin metabolism. Because it carries some lots of liver functions, the uptake function, the transport function, the secretion function, and the excretion function, all in one cycle. We all remember how bilirubin is liberated. It is liberated from the end product of RBCs when the hemoglobin is detached into globin and heme. Then the heme is detached into iron and bilirubin, and bilirubin travels in the circulation bound to albumin, but it is still unconjugated, and we call it unconjugated bilirubin or indirect bilirubin. Of course, the destruction of the old RBCs happens in the reticuloendothelial cell. The liver, by its ability, it will start to uptake the bilirubin bound to albumin in the circulation and enters it into the hepatocytes. They are carried inside the hepatocytes where they get conjugated by the bilirubin diglucuronide. The conjugation of bilirubin with the diglucuronide makes it the conjugated or what's called direct bilirubin. After that, it's going to be transported to the biliary side of the hepatocytes where they get secreted into the biliary canaliculi and then the biliary tubes and to the common bile duct where it can be excreted in the small bowel in the second part of the duodenum to be helpful in the digestion and absorption of the fat and fat soluble vitamins. After that, there is a very little amount of it will be excreted in the stool. It's called stercobilinogen or stercobilin, which gives the stool its color. And that's why when we have a case of obstructive jaundice and no bilirubin be excreted in the stool color becomes clay in color. Big part of the excreted bilirubin will be converted to urobilinogen, where it returns back to the liver through what's called enterohepatic circulation. Very, very, very little amount will be lost in the urine in the form of urobilinogen and will be excreted in the urine. And here it is not responsible on for the color of the urine. But of course, when we have a case of jaundice and there is excess urobilinogen secreted in the urine color will be dark. Okay, now we have known the anatomy of the liver, the histology of the liver, the functions of the liver. So let us say what happens when we damage this liver? What happens when there is liver cirrhosis? What is cirrhosis? What is this term? What is there? What comes? What is its origin and what does it mean? Okay, cirrhosis is derived from the Greek word "keros." Keros means tawny. Tawny is a color that is orange yellow, a little bit between orange and yellow. It's called tawny. Tawny is the Greek word "keros," and because those patients they develop the yellowish discoloration because of the jaundice they have, so the disease was called cirrhosis or cirrhosis. So the clinical entity of liver cirrhosis was first described in books by the very famous René Lenneck, and of course we remember from pathology Lenneck cirrhosis, and this was from the year 1819. It doesn't mean that there was no cirrhosis before that. No, there was cirrhosis, of course, before that, but it was not described in books the way that Lennox did. Of course, another very, very famous thing that is attributed to Lennox is the Lennox stethoscope that we all know. So let's have some definitions. First, cirrhosis is a consequence of a chronic liver disease because we need a chronic damage to the liver for cirrhosis to develop. So how cirrhosis develops? It characterized by fibrous scars surrounding outside and regeneration nodules which are lumps of hepatocytes trying to form new hepatic cells, but unfortunately, because they are not arranged in the plates and in the acini, in the hexagonal form, and with the presence of central veins and the presence of portal triangles, this architectural form makes it unable to perform its exact function. So those lumps of regenerating hepatocytes, which are surrounding by scar tissue or fibrous scar tissue. These are called the regeneration nodules surrounded by the fibrosis. This is progressively leads to loss of the liver functions when they start to involve more and more areas of the liver and more of the hepatic tissue. Remember the look of the healthy liver we have seen just a few slides ago? This is the look of a cirrhotic liver. And we can all see the irregularity and the nodularity of the surface. And it's quite obvious for us the presence of the regeneration nodules inside the tissue, as if this liver is made of thousands and millions of small balls of fibrous tissue including the regeneration nodules inside. This is the pathophysiology of cirrhosis or how cirrhosis is developed. As we said, we have a primary event that is causing injury to the hepatocellular elements. We will speak about such injurious things after a while, like viruses, like toxins, like so and so. This initiates inflammatory process with cytokine release. Unfortunately, the cytokine releases toxic substances that destroys the attacking thing as well as the normal hepatic tissue. This results in tissue damage and destruction of hepatocytes, bile ducts, vascular endothelial cells, and more importantly, is the loss of the relationship between these structures all together. This leads to trial of repair. Unfortunately, this trial is in vain. It is not helpful. Why? Because the proliferation is in the form of lumps or balls of cells which lose the relationship together. They are not arranged like the palisading form and the plate form like we have seen in the histological arrangement of the liver. This, of course, makes it unable to survive, start to die, and form fibrous scars, and this makes those lumps become regeneration nodules. What are the causes? Of course, the most important cause of liver cirrhosis was viruses, especially virus B and C. But unfortunately, this is now not the first cause. The first cause now is the non-alcoholic steatohepatitis or the fatty liver disease. Or the new nomenclature of it is the metabolic associated steatotic liver disease. And of course, this will be mentioned completely in another lecture. Of course, in the Western societies, still alcohol plays a very important role in development of liver cirrhosis, especially in those who are having prolonged and regular and heavy alcohol usage. Autoimmune disorders like autoimmune hepatitis and prolonged cholestasis like extra or intrahepatic cholestasis. There are also some less common causes like vascular causes like the veno-occlusive disease, Budd-Chiari syndrome, constrictive pericarditis, and long-standing right-sided heart failure, what is commonly known as cardiac cirrhosis. There are some toxins and drugs like methotrexate, amiodarone, alpha-methyl-dopa, and isoniazid used for treatment of tuberculosis. Some metabolic disorders, and also this is going to be mentioned in another lecture, like hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and the glycogen storage diseases. And lastly, some genetic disorders like cystic fibrosis and Crowley syndrome and congenital biliary atresia. So these are the etiologic factors for liver cirrhosis. What are the symptoms of liver cirrhosis? Now we know the liver functions and we will start to know what's going to happen. Unfortunately, the presentation goes through one or three forms. The first and the most common form, unfortunately, is asymptomatic, discovered by chance during routine checkup, pre-employment, pre-operative assessment. You find that there is some affection of the liver functions, and you start to investigate, and you find that the patient is already cirrhotic, had no symptoms at all. All the entire years that preceded the time of diagnosis. The second thing is the symptom of a condition that is commonly associated with chronic liver disease. I mean, it's not the chronic disease, but the, something that's very commonly associated, like gallstones. Patients have gallstones, they start to have right hypochondrial pain, and they go to the doctor, they make ultrasound, and the ultrasound find that the liver is a little bit cold. And patients with recurrent pancreatitis, especially those who are alcoholics, during the checkup for the pancreatitis, they find that there is something abnormal about the liver, and they find that they are cirrhotic. Those who are having carotid enlargement, lid retraction, transcontracture, and muscle cramps, all those are patients when they start to be investigated, commonly to be discovered to have a liver cirrhosis. And lastly is the symptom of complication like portal hypertension, like liver cell failure, which is, we say that there is liver cirrhosis is a vascular failure in the form of portal hypertension and cellular failure in the form of manifestations of chronic liver disease. So, what are the signs? As we said, it can be divided into cellular failure and into a vascular failure. And we let us know what are the signs of liver cirrhosis. Of course, one is very common, the spider angiomata or the spider nevi, and these are uh, vascular lesions with central arterioles and surrounded by many smaller capillaries, and hence the name spider, because it looks like a spider with a trunk and very thin legs. So it looks like a spider. This is due to the increase of estradiol, and they occur in almost 1/3 of the cases. The so peculiar about spider nevi or spider angiomata that they are only present in the distribution of superior vena cava. In fact, nobody knows why it's only in the distribution of superior vena cava. It means that it cannot be seen in the lower limbs or the lower parts of the trunk. And this is the look of the spider nevi or the spider angiomata with the central arteriole and so many smaller capillaries arising from them. And of course, we all know the test of it for blanching when you carry this glass slide and you start to compress it. When you see that it's going to be lost because you have compressed the central arteriole, and this is how we differentiate it from insect bite by a glass slide. The slides that we used previously in the pathology and histology and so on. Second most common, of course, sign is the palmar erythema. Palmar erythema is erythema and exaggeration of a speckled mottling pattern of the palm with a central pallor. It must have a central pallor, because if all the palm is erythematous, it is not called palmar erythema. It's of course due to alteration of sex hormone metabolism. As we can see here, that there is excessive speckling and excessive erythema in the thenar, hypothenar, and bases of the fingers, with central triangular pallor in the middle of the palm. This is the palmar erythema. Gynecomastia, of course, this is benign proliferation of the glandular tissue of male breast. There is no gynecomastia in the females. In the enlargement of the breast size in the females, it's called breastomegaly. It's not gynecomastia. And it will be mostly fat, not glandular. This glandular tissue, the proliferation of glandular tissue, renders it rubbery, firm mass, and of course painful on pinching because it is glandular tissue. This happens in 2/3 of the patients. And of course, we know that there are some drugs increases the formation of this. It can be unilateral, it can be bilateral, it can be of variable size. Of course, because of the accumulation and distribution, the disturbance in the sex hormones, there would be hypogonadism manifested as impotence, infertility, loss of sexual drive, and testicular atrophy, of course, due to primary gonadal injury by the original attacker, or the suppression of the hypothalamic or pituitary function, which decreases the gonadotropins and the impairs the sex hormones metabolism. The liver size is something that is not important at all. It can be larger in size, it can be normal in size, and maybe sometimes it is shrunken in size. Not unlike the spleen. Enlargement of the spleen is always important. Enlargement of the spleen is the first sign of portal hypertension. So the congestion of the spleen and the enlargement of the spleen makes this a sign of portal hypertension. Ascites. Ascitis is very peculiar because it can be because of the cellular function or the loss of cellular function, which is the hypoalbuminemia because of the liver cell failure, and also vascular failure because of the portal hypertension, which localizes the fluid accumulation into the peritoneal cavity. So the ascites is the accumulation of fluid in the peritoneal cavity, giving rise to fullness of the flanks, like we say in the clinical rounds, and it needs at least 1.5 liter to be manifest. And that's why less amounts of ascites needs more forms like the knee elbow or the use of ultrasound, which can detect very minimal amounts, of course, of fluid in the peritoneal cavity. It can be associated sometimes with hydrocele or penile inflammation or swelling, which is the swelling of penile shaft. And in fact, it depends mainly also on the hypoalbuminemia. The more the hypoalbuminemia, the more the edema develops. Of course, we can see now the generalized abdominal fullness with the fullness of the flap. What about caput medusa? Caput medusa is one of the parts of the opening of the portosystemic shunting or portosystemic collaterals, because in portal hypertension, the umbilical veins, they start to open again, and the blood from the portal venous system will be shunted through the peri-umbilical veins into the umbilical vein and ultimately the abdominal wall veins, and they look as caput medusa. Caput medusa, we all know the myth about the medusa island gorgones, which could turn anyone who looks at them into stone. So they need to be to cut, and their hair was made of snakes. So this is the look of the caput medusae, or the serpentine look of the collaterals opening from between the periumbilical and the abdominal wall veins. Pitor hepaticus, of course, is a foul, funny odor like rotten apple because of the accumulation of dimethyl sulfide, and it can appear from the breath of patients with liver cirrhosis, especially when they are start to develop hepatic encephalopathy or hepatic encephalopathy. Jaundice is the yellowish discoloration of skin, eye, and mucous membranes. It happens only when the bilirubin level increases to the level of 2 or 3 milligram. Of course, we know that the maximum bilirubin level is 1. So there is some area which is there is hyperbilirubinemia, and the jaundice does not look yet. Urine also might appear a little bit dark. Asterixis, which are flapping or coarse tremors, they are bilateral, synchronous or asynchronous. Yani they can happen together or they can happen alternatively. Flapping of the outstretched dorsiflexed hands. We ask the patient to stretch his arms and flex his hands as if he is pushing a wall or something like that. And of course, if we have starting hepatic encephalopathy or severe liver failure, we will see these flapping tremors or coarse tremors or asterixis. So let us see how it looks like. This is fetal hepaticus, and this is jaundice, and this is asterixis. Look at the video. The video is not playing. Wait, wait. Sorry, I had some technical problems. So, as we said, there is fetor hepaticus, and of course, there is jaundice, and we can so let's look at the video with the flapping tremors. We can see that the hands are flapping like that, either synchronously or asynchronously. Okay, so the next sign is something called Crovelier-Baumgarten murmur, which is the venous hum that we can hear in the epigastric region because of the turbulence of blood flow in the collateral connections between the portal and the umbilical vein, the one that are causing splenomegaly, causing esophageal varices, causing the caput medusae. The collaterals that are opening in this area can be heard by the stethoscope as venous hum heard in the epigastric region, and of course, other signs like weakness, fatigue, anorexia, and weight loss. There are some changes and very important changes in the nails. And of course, it's very commonly in an examination that a patient with liver cirrhosis, you are only asked to examine the hands. Of course, remember that we said in the hands there would be pulmonary erythema, there would be flapping tremors, and would be, of course, the nail changes. Something called the Merkes nails, which are paired horizontal bands separated by normal color due to hypoalbuminemia, leukonychia, which is white opaque nails, Perez nails, which is proximal two-thirds of the nail plate appears white, and the distal one-third is red or dark brown due to hypoalbuminemia, and of course, clubbing, which is the angle between the nail plate and the proximal nail fold will be more than 180 degrees. These are the Merkes nails, as we can see, horizontal colored lines. These are the leukonychia. Of course, we can see the white patches. And here is the teres nails, which is proximal two-thirds, which are white, and the distal one-third is brown or red. And of course, the clubbing, we all know about it, and the open window sign of second degree clubbing and so on. What are more signs? Hypertrophic osteoarthropathy, which is chronic proliferative periosteitis of the long bones that can cause considerable pain. Dupuytren's contracture, it is thickening and so shortening of the palmar fascia that leads to flexion deformity of the fingers. And it's more common, of course, among alcoholic cirrhosis. And it's not very well known why it happens. It was thought to be due to accumulation the proliferation of fibroblasts disorder or disorder in the collagen deposition. Nobody actually knows, and it is relatively common. It happens in 1/3 of the patients. This is the hypertrophic periosteitis, and this is the look of the Dupuytren's contracture. This is a very nice picture, in fact. So how can we diagnose a patient with liver cirrhosis? The gold standard diagnosis of cirrhosis is to detect the pathological feature of the regeneration nodules and fibrosis and so on, which is liver biopsy. Of course, liver biopsy now is not very well, not very common to be done. Histologically, it was divided into micronodular, macronodular, and mixed. Now we don't see that very common. It's the connection between different etiologies makes no particular pattern of cirrhosis in the histology. Laboratory investigations is Of course, there are some non-invasive forms now to detect the liver fibrosis and liver cirrhosis, like the fibroscan and non-invasive techniques. But they are not very they cannot be replaced. They cannot replace the liver biopsy in the form of saying that this is truly cirrhosis or not. But of course, they are used widely now because the liver biopsy is getting less and less to be done. Blood picture, of course, we can see microcytic hypochromic anemia because of the GI blood loss. Normocytic normochromic sometimes be found. Leukopenia and thrombocytopenia, patients with splenomegaly and hypersplenism. And of course, we will find prolongation of the prothrombin time and concentration because of the failure of formation by the liver. Serum albumin will be decreased with increase of gamma globulins and serum bilirubin. Of course, the aminotransferases, which are the ALT and AST, may be elevated, but in cases of advanced cirrhosis where there is no hepatocytes to be destroyed again, they will be normal. Blood glucose is going to be impaired, and as we said, that liver is responsible for the metabolism of carbohydrates and glucose. So, impairment of glucose tolerance is found in half of the patients, and they developed frank cirrhosis after a while, diabetes after a while in 1/3 of the patients, especially those who are post-hepatitis C. We said that will be increase in the bilirubin and urobilinogen in the urine. Other laboratory studies performed are in patients with newly diagnosed cirrhosis will be serology for hepatitis markers, autoantibodies, anti-nuclear and anti-smooth and anti-mitochondrial and anti-liver kidney microsomal antibody, ferritin, transferrin saturation, which are markers for iron overload when we are suspicious of hemochromatosis, copper and ceruloplasmin. Of course, this is not the best now. The best now is the 24-hour urinary copper excretion, immunoglobulin levels, IgG, IgM, and IgA for distinguishing further causes, and alpha-1 antitrypsin and alpha-1 antitrypsin. Abdominal ultrasound, of course, the liver may look coarse and echogenic. The edge will be irregular, and in advanced cases, the liver will be shrunken because of portal hypertension will show as dilated portal vein, splenomegaly, and ascitis also can be detected as well. As we can see on the left side, this is the normal liver, and on the right side, this is the cirrhotic liver. Endoscopy. Of course, upper GI endoscopy may show varices in the esophagus or in the stomach. That's called gastric varices. There would be congestion of the gastric mucosa because of the portal hypertension. This is called portal hypertensive gastropathy or congestive gastropathy. We see now this is the look of the normal esophagus, and we see now the esophageal varices, which are the longitudinal vascular or venous tubes engorged with blood due to the opening of the portosystemic shunting and the presence of portal hypertension. And unfortunately, they can bleed like that, and the blood would be spurting, and the patient will manifest as hematemesis. Or, of course, the bleeding rate, if it is less than that, it would present by melena. What are the complications? Of course, liver cell failure, portal hypertension, spontaneous bacterial peritonitis, hepatic encephalopathy, hepatorenal syndrome, and the very unfortunate hepatocellular carcinoma. What is the treatment of liver cirrhosis? Although the development of cirrhosis is an irreversible process, many lines of treatment can be provided for the patient to ensure a better quality of life and promote the regeneration of normally functioning hepatocytes, like, for example, the nutrition. Of course, caloric requirements are supplied as normal individuals. Good intake of carbohydrates and moderate amounts of fats should be supplied. Of course, proteins are provided in good amounts and in higher amounts in poorly nourished patients. In patients with encephalopathy, the proteins should be restricted. And we say proteins, we say only animal protein. I mean, plant proteins are not to be restricted, as well as the milk and eggs. Salt restriction, of course, in patients with ascites. What is the treatment of underlying cause? Is abstinence of alcohol, chelation of copper in Wilson and hemochromatosis, antivirals in viral hepatitis, corticosteroids in autoimmune hepatitis, and the treatment of complication is ascites, encephalopathy, bleeding, spontaneous bacterial peritonitis, and renal impairment. What, of course, is the definitive treatment of such patients is, of course, liver transplantation is the treatment of choice. Okay. What about the portal hypertension? We all know the portal vein. Portal vein is the formation of union of superior mesenteric and splenic veins. Normally, the pressure in the portal vein is low. It's about 5 to 8 millimeter mercury. And in many conditions, portal hypertension might develop. In conditions pre-hepatic, due to blockage of the portal vein before of the liver, and intrahepatic due to distortion of the liver architecture, which elevates the pressure in a hepatic sinusoid, the hepatic central veins, and of course, the portal pressure. Post-hepatic, which is rare due to venous blockage outside the liver. Okay, these are the pre-sinusoidal causes, extrahepatic or intrahepatic. Extrahepatic, like portal vein thrombosis, we see it sometimes in pediatric population. Cavernous transformation of the portal vein, extrinsic compression, arterioportal fistula, and massive splenomegaly. Intrahepatic causes like schistosomiasis, sarcoidosis, primary biliary cirrhosis, and idiopathic portal hypertension, which is the non-cirrhotic portal hypertension. Sinusoidal causes like the cirrhosis and the alcoholic hepatitis and the vitamin A toxicity, and the post-sinusoidal are the vascular disorders like veno-occlusive, Budd-Chiari, hepatic venous or inferior vena cava web, restrictive heart disease, constrictive pericarditis, and severe congestive heart failure. Okay, due to that, the portal pressure will be elevated above 10 to 12 millimeter mercury, and of course, the compliant venous system will dilate, and collaterals will start on what's called the portosystemic collaterals. The portal pressure is elevated, so it tries to convey this pressure into the systemic, and the main sites of collaterals will be the gastroesophageal junction, which are superficial and tend to rupture in the form of esophageal varices, in the rectum, and sometimes they cause rectal varices, left renal vein, diaphragm, retroperitoneal, and the one that we mentioned previously, the anterior abdominal wall, which is via the umbilical vein that is causing caput medosi. Of course, those in the left renal vein, diaphragm, and retroperitoneal, they do not bleed. The collaterals of the gastroesophageal junction, we said, manifest as varices, rectum, rectal piles or rectal varices, anterior abdominal wall are the formation of caput medosi. Patients with portal hypertension are often asymptomatic, and the clinical evidence of portal hypertension would be splenomegaly, as we mentioned before. Of course, the clinical features of chronic liver disease, if there is chronic liver disease, will be manifest. And unfortunately, the presenting feature would be hematemesis, ascitis, or portosystemic encephalopathy. Approximately 90% of patients with cirrhosis will develop gastroesophageal varices over 10 years, but only 1/3 of those will bleed from them. Bleeding is likely to occur in large varices, which have the red signs on them, on varices diagnosed at endoscopy, and in cases of severe liver disease. We see now this video shows us esophageal varices that are bleeding We can see now the bleeding. We start to rinse some water this is the cap of the band ligation. We can see now the spurting of blood. We can see the spurter now. You see it? You see it? The spurter now? You see it? So we start to make some suction. We suck the varix inside it, and then we fire the band to surround it, and then we start to make flushing to make sure that the bleeding has stopped and the band is fired in the appropriate place. So we can see now in the upper left picture the large varices, and the right upper picture there is a spurter. There is another spurter on the lower left, and the bands applied on the lower right picture. This is the look of portal hypertensive gastropathy and gave, which is a gastric antral vascular ectasia, something like vascular ectasias that happens in portal hypertension and might cause bleeding as well. And the treatment of them would be by argon plasma coagulation by the endoscope. So what is the treatment? The treatment for in bleeding varices and so it will be resuscitation, antibiotics. Gastric lavage is debatable. Balloon tamponade is now obsolete. So there are some articles speaking about self-expandable metal stents, transjugular intrahepatic portosystemic shunting, emergency surgery. But of course, for the varices, we make the band ligation, and the follow-up would be follow-up of the esophageal variceal ligation, medical treatment by non-selective beta blockers, and preferably now the carvedilol is the one that is used widely. Of course, we can make tips, and definitive treatment would be the same liver transplantation. And thank you very